Good evening. This video covers the 2025 AHA/ACC and 2024 ESC hypertension guideline updates, focusing on risk-based management, terminology shifts in emergencies, and practical OPD management. If you are still managing hypertension based on 2017 guidelines, you are already behind. The 2025 AHA/ACC and 2024 ESC guidelines have finalized a massive shift. Hypertension is no longer just a number issue, it's a risk issue. The big picture: global control rates are still low, 20%. The new focus is on early intervention, using the prevent risk calculator instead of ASCVD equations, and tackling hypertension to prevent cognitive decline. Terminology shift: say goodbye to hypertensive urgency. It is now severe hypertension, 180/120 without end organ damage. Today's coverage: OPD management updates, investigations and drugs, and emergency protocols, hypertensive emergencies. OPD management, diagnosis and investigation. The new diagnostic paradigm: confirmed BP equal or MRE than 140/90 mmHg is hypertension, but elevated BP, 120/139/70/89, now warrants aggressive screening for high-risk patients. Key update 1: Prevent equations, replace pooled cohort equations, PCE. Prevent includes renal parameters, eGFR, albuminuria, and 30-year risk assessment, not just 10-year risk. Key update 2: Routine albuminuria screening, routine urine albumin to creatinine ratio, UACR, screening is now recommended for all hypertensive patients to assess cardiovascular kidney metabolic risk. Out-of-office monitoring, home blood pressure monitoring, HBPM, is now considered the gold standard for management and titration. Caution: do not rely on cuffless wearables, smartwatches, yet. Secondary hypertension: screen for primary aldosteronism in all patients with stage 2 hypertension, not just resistant hypertension, and those with diuretic-induced hypokalemia. OPD management, treatment and targets. Targets: general target is 130/80 mmHg, but a stricter target of less than 120 mm of mercury systolic is encouraged for high-risk patients if tolerated. PPROAD/ESPRIT trials. Single pill combinations, SPC first-line therapy for stage 2 hypertension. Combine ROSI, ACI/ARB, with a calcium channel blocker, CCB, or diuretic to improve adherence. Lifestyle updates. Salt: reduce sodium to 2g/day. Potassium: promote potassium-rich diets. Potassium-based salt substitutes, recommended to treat/prevent HTN, except in severe CKD or on potassium-sparing meds. New drug class focus: SGLT2 inhibitors are now recommended for patients with HTN plus CKD/diabetes for joint BP and kidney benefit. Renal denervation: RDN given a class IIB recommendation for resistant hypertension despite optimal medical therapy. Emergency management: hypertensive emergency. Definition: BP equals or 180/120 mmHg with acute target organ damage, EOD. Key update: stop reflexive IV therapy. Severe hypertension, 180/120 without acute EOD, should not be managed with 4 drugs in the ER. Use rapid oral titration in the OPD setting. Management goals. First hour: reduce mean arterial pressure, MAP, by forward/equals 25%. Next 2 to 6 hours, goal is 160/100 mmHg. Specific emergency scenarios, updates. Acute intracerebral hemorrhage, ICH, promptly lower SBP to 130 to 140 mm of mercury for 7 days. If SBP falls less than 130, stop meds. Acute ischemic stroke: avoid aggressive lowering, less than 140 mm of mercury is harmful, if successful endovascular reperfusion occurs. Aortic dissection: rapid reduction to SBP. Less than 120 mm of mercury within 20 minutes. Special populations: pregnancy and frailty. Pregnancy: CHAP trial evidence dictates initiating treatment at /equals 160/110 mmHg, or /equals 140/90 mmHg of chronic HTN. Preferred agents, labetalol, nifedipine, long-acting. Contraindicated, ACI/ARBs/MRAs/nitroprusside atenolol. Frailty/elderly, individualized target. If symptomatic orthostatic hypotension occurs, it is safe to continue medication to reach. Conclusion and takeaways. Use Prevent to measure risk. Screen for CKD/primary aldosteronism early. No urgency, just severe hypertension. Single pill combinations first line. Closing, the future of hypertension is personalized and risk-driven. Thanks for watching. Note, these updates are based on the 2025 AHA/ACC and 2024 ESC guidelines published, providing the most current evidence as of March 2026. Which of these breakthroughs do you think have the biggest impact? Let me know in the comments. Disclaimer: the video is for awareness purpose only and specific advice must be taken from the concerned experts in person before acting on any provided info. The creator, publisher and YouTube will not be liable for any incorrect consequences/results/self-medication. Don't forget to like and subscribe for your regular dose of medical and management news. Stay healthy, and I'll see you in the next one.